It's my pleasure to introduce Dr. MacDowall, who's joining us from Uppsala University in Sweden. We had the opportunity to visit her center as part of the CSRS Traveling Fellowship about 5 years ago. She's published a fair amount of papers regarding this topic, and we look forward to learning more from you.
Thank you. So I have nothing to disclose on this topic. So we do our surgery and we're pretty sure we got the indications right and the post-op pictures look perfect, but why did the patient not improve after surgery? And what can we do about it? So we know about some negative predictors to outcome. We heard in the session before about BMI, but other negative predictors is, we know that female smokers are doing worse in degenerative foraminal stenosis with radiculopathy, and in degenerative spinal stenosis with myelopathy, we know that older age and the long duration of symptoms, more severe myelopathy, those patients are also doing worse after surgery, or not as good as the other one, at least. But there are also some unknown factors. And this is the same as Dr. Riley presented, but in color, because I have the graph. So I made it in color. So depression has a larger impact on treatment outcome than the treatment method. And you can see here that the blue line are the depressed patient and the red are non-depressed patient. And it's a statistical significant difference. The confidence intervals are not overlapping, and the depressed patient, they improve, but not, they are not doing as well as the non-depressed patients. So a little facts about depression. We've heard some of it already. I repeat, I think it's interesting that 1 out of 5 people, they have depression somewhere during their lifetime. The incidence peak between 50 and 60 years. And we've already talked a little bit about hospital anxiety and depression score. I like that score a lot because I did some research about it. And actually, it's correlated to Neck Disability Index. So if you don't have hospital anxiety and depression score, you can also use Neck Disability Index as a tool to raise a yellow flag towards depression. So the regions in the brain associated with emotional and sensory responses to pain and the regions affected by depression, they overlap anatomically. The same dysregulation of dopamine and serotonin is common with both chronic pain and depression. So it's important to know that depression and pain, they walk hand in hand. And patients with preoperative depression, they need more analgesic after surgery than non-depressed patients. And that is because depressed patients, they show greater emotional reactivity, which can lead to a diminished ability to regulate pain. And anxiety play also an important role in pain perception. So, depression affects cognitive domains like attention, memory and learning, which is important in rational understanding of disease and postoperative treatment. And it also affects executive functions like planning, decision-making, task initiation, and multitasking. And psychomotor processing, like sensory, perceptual, and motor operations. And it affects functional exercise and lead to resistance towards rehabilitation training. Depression affects inflammation and immunity, so the patients have a high level of inflammation marks and changes of neuroendocrine immunity, leading to more inflammatory cytokines, and NSAIDs actually has an antidepressant effect. But I think it's important to say that also depressed patients, they improve after surgery. So depression is no argument not to treat patients with surgery. And depression and pain needs to be treated simultaneously to be effective. So now some hands-on tips. What can we do about it? Well, in my institution, hospital anxiety and depression scale and the pain drawing, we use them because they are both validated tools and can predict outcome after cervical spine surgery. So at my institution, we have specially educated physiotherapists that screen and do a thorough physical examination of the patients prior to the doctor's appointment. And once a week, we have a conference, the surgeon and the physiotherapist, where we go through the screening, the physical examination and the MRIs in each patient. And in that way, we may sort out the patients that need something extra or something else. And we also have the option to refer the patients to multidisciplinary care, which is part of the pain clinic or pain department at our hospital. So active versus passive coping. Active coping is generally associated with more adaptive adjustment and characterized by strategies such as problem-focused coping, and passive coping is defined as maladaptive strategies when faced with stressful situations such as negative self-targeting and avoidance. And I see my time is running up, so I'll go a little bit quickly. So the patient delivers herself into your care, so the active patient becomes passive and rely upon you to fix her problems. So therefore it's important that after the surgery the patient gets help to switch back from passive to active coping again. And how do we do that? Well, the follow-ups are equally important as the pre-op screening. Our specially educated physiotherapists, they have a follow-up meeting 4 weeks after surgery with screening and physical examination. And they then send feedback to the surgeon so that the surgeon may act upon this well in advance before the 3-month follow-up, which is a doctor's appointment. So referral may be sent to multidisciplinary care if needed. So, in summary, it's important to have time for the patients that need extra time. Time for preoperative screening. I recommend the hospital anxiety depression scale and pain drawing. We use that in my institution. We think it works well. Equally important is follow-up screening, and you are not supposed to fix everything yourself. There are plenty of other disciplines that are experts on depression and anxiety and can help you if you just reach out and ask them. And I just want to make some advertisement about our next European CSRS meeting, which will be held in Stockholm, and I will be your local host on that meeting. Thank you.